Hello and welcome to Attentive Healthcare Solutions webinar, Transformation in Annual Reporting for NCQA PCMH. My name is Chelsea Grover and I'm the Marketing Communications Coordinator for Attentive. Before we dive into today's webinar, I wanted to take a moment to explain the process for today's presentation. First, I'd like to mention this webinar will be recorded. We'll send out a copy with the slides along with the recording within the next week. Also, I wanted to announce that we do have a lot of slides and information to get through today. But if we happen to run over a few minutes, we'll just keep going and still do questions at the end. We understand if you need to jump off the call before we finish, but don't worry because again, we'll be sending out the recording within a few days so you can catch up on whatever you might have missed. Okay, so now that that's out of the way, I wanted to share a bit of who we are with you for those of you who aren't familiar with Attentive. We specialize specifically in NextGen healthcare. We are passionate about providing solutions for our healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. To sum it up, we do everything NextGen. And we also have two add-on productivity solutions for NextGen, ChartGuard and Refund Manager. Next, I wanted to mention an upcoming webinar on September 11th on automating your practice's health information security. In it, we'll help you understand key areas of health information security, such as the need for robust security, handling of sensitive patient information, and regulatory standards and laws. This webinar is intended to help healthcare provider practices reassess their health information security and consider how automation and other tools available can help alleviate the burden of keeping your patient's data secure and protect your organization from fines and penalties. And again, that's on September 11th. We'll send out an invitation for that in a few weeks. Hope to see you there. Okay, so back to today's webinar on the NCQA PCMH Transformation in Annual Reporting. At the end of the presentation, we'll open the floor up to questions from you. We'll answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And again, there is a lot of content in today's presentation, so if we run over, we'll continue to stay on the line to answer all the questions at the end of the webinar. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. And if you experience audio issues, please use the chat box to let us know so we can resolve them. So without further delay, I'd like to introduce our presenters for today. Lindsay Lanning is Manager of Client Development, and Lexi DeMarsh is Manager of Consulting Development. Sorry about that, Lexi. Still getting used to your new title. So Lindsay, the webinar is all yours. Feel free to get started when you're ready.
Great, thank you, Chelsea. Well, hi everyone, and thank you for joining us for our webinar on Transformation and Annual Reporting with NCQA PCMH. So today's presentation will be beneficial no matter if you already are part of a PCMH currently, or if you're just considering becoming one in the future. Either way, if you just don't feel like you have all the information you need in order to ensure success, you've come to the right place. We're going to address questions and concerns of PCMH transformation and annual reporting with our very own PCMH certified content expert, me. The reason why we put this on is because we want to make understanding the 2017 PCMH standards, the new concept of annual reporting for already recognized practices, the new NextGen PCMH reporting suite, and the overall benefits of becoming a PCMH easy. We realize there's a ton of information and that information is constantly changing, and we want to help you decipher what's important and what you need to know when it comes to maintaining your certification or starting this transformation in your practice. So what I'm trying to say, and probably should have just started with since we have a ton of info to cover, is that we understand what's required. We know the best practices to be successful, and we know how to make your practice and providers more productive and profitable. Now, as a disclaimer here, we are strictly focusing on NCQA PCMH program. No other type of PCMH recognition will be covered, although many of the general concepts we cover in regards to things like practice benefits, ROI on PCMH, and kind of elevating that conversation in your practice would apply. I thought it was important to point this out sooner rather than later. Also wanted to point out, as an NCQA PCMH CCE, I have access to amazing resources and in-person training that really largely fed into this webinar. So most of the graphics and a lot of the overall content has been taken directly from NCQA in order to really provide you with consistent and accurate information. One of our goals with this webinar was to make all this information easier to dissect and digest at the practice level. So where I had 4+ kind of like 100 to 200 slide presentations from NCQA to go through, I was able to scale it down and pick out what exactly you needed to know and then add in what you should know. So a lot of the takeaways and tips are coming directly from NCQA evaluators who conduct the transformation process or annual reporting requirement reviews. So up first on our agenda today is just introducing or reintroducing you to the PCMH basics. Now, if you already are a PCMH and completed transformation, this will likely be review. However, there's still some great information to reiterate the importance of this program in your practice in order to maintain your practice support. So it will serve as a great refresher to you on what's required until we get to annual reporting, where I know abundance of you are currently gearing up to complete. So for those of you on the call not yet recognized, you may be wondering, what even is this? Well, the patient-centered medical home is a care delivery model whereby patient treatment is coordinated through their primary care physician. The objective here is to have a centralized setting that facilitates partnerships between individual patients and their personal physicians or clinicians. So this really emphasizes care coordination and communication to transform care based on the patient's preferences and needs. So the patient-centered medical home really is a model of care that puts the patient at the forefront or at the center of care. Its kind of goal here is to build better relationships between patients and their clinical care teams. And I also want to note, because I get this question a lot, PCMH recognition is voluntary for practices. You choose to participate in it. It's not required, but it does put your practice at such an advantage in so many ways, which we'll go over in a few slides of how to recognize and relay that value of PCMH to your team. So at a high level, if we ask, why is this important? Why do we even care enough to talk about this topic today? We have to take a step back and look at the current landscape. And to sum it up, the cost of healthcare are unsustainable. Since 2002, the cost of healthcare has more than tripled, which has thrown us headfirst into this transition from volume to value-based care. It is everywhere, and there is no escaping it. It kind of reminds me of our current situation in the office, Lexi and Chelsea can relate to, where we are currently transitioning from Skype for Business to Microsoft Teams. And there is no turning back. And there was no just dipping your toe in to test the waters. It's jumping headfirst into the deep end. But this is our reality. Even in the healthcare industry, we are rewarding value and improving quality. Those are our main goals from here on out, and provide that high-value healthcare that cuts down on costs. So we know now, with the increased importance on social determinants of health, that 20% of the people generate 80% of the healthcare costs. And that's where this PCMH model works to move healthcare toward greater value. So you might be asking, how did we get here? How do we find ourselves in a place with such exuberant healthcare costs? Well, first off, we were functioning in a payment system that primarily rewarded volume rather than value. Because of this, we always had a reactive focus on symptoms rather than a proactive health management focus. But besides this, we also see fragmentation, so poorly coordinated healthcare, and no real kind of champion to help patients navigate the system. There's limited transparency and information sharing. Physicians really lack the complete picture necessary to manage their patients' health. We also see insufficient resources directed to primary care, which has contributed to a primary care shortage right now. PCMHs really are doing their part in addressing these issues and lowering costs through better chronic care management, preventative medicine, and coordination across care settings, leading to the impressive numbers you see on your screen with that graphic. Now, the PCMH model is able to do all of this because of its alignment with the triple aim, which we now call the quadruple aim. So if we look deeper into what the quadruple aim tries to accomplish, we can begin to understand how this model can actually transform a practice with this widely accepted industry initiative at its core. So in 2007, the Triple Aim initiative was launched, and it focused on improving population health, improving the patient experience, and of course, reducing the cost of healthcare. Now, just recently, due to many factors such as physician burnout and shortages, the Triple Aim has actually been expanded to be the Quadruple Aim, and that includes a physician-focused aspect of improving the work life of healthcare providers. This slight shift in mindset by the healthcare industry to not only focus on the patient experience, but also the provider experience is fully supported and incorporated by the PCMH model and encourages practices to perform much more efficiently. So we keep throwing this term, patient-centered care, out there. I mean, it's what the P and C in PCMH stand for. It's obviously an important concept, really, on how this model functions and how it improves care while lowering cost. So what is this? Well, number one, it's an ongoing relationship with a personal clinician, meaning that clinician is their first point of contact, their continuous caregiver, and they're providing the comprehensive care. It's being responsible for all of your patients' healthcare needs, not just the ones you provide. It means care for all stages of life. This includes acute care, chronic care, preventative services, and even end-of-life care. And lastly, it means team care. So this includes clinicians who take responsibility for the care of their patients, but it also includes their nurses, any specialists, urgent care providers, behavioral health providers, et cetera, that treat your patient. It really is what it sounds like. It's putting the patient in the center and making sure their care revolves around them and their needs. And on that same note, we need to understand what patients want or what they expect out of their primary care providers to better serve them and their needs. Now, according to NCQA, patients want long-term partnerships, not hurried visits, better access through expanded practice hours and online tools. They want to participate in shared decision-making. They want lower costs from reduced ER visits. They want higher satisfaction among patients and providers, and they want care that's patient-centered and coordinated among providers. Now, if we all take a second and we take our clinician, our medical practice staff hats off for a second, and we put our patient hats on, this is what we all want, isn't it? This makes sense. If we imagine ourselves as a patient, this is exactly what we're looking for. So how do we leverage this information to deliver care that better serves patients and also saves money while still providing the highest quality of care possible? Well, one possible answer to this is PCMH. NCQA offers the most widely used PCMH recognition program for providers. It really is the most widely adopted medical home evaluation program in the country. It was actually the first evaluation program released in the country. And you can see over the past 2 years alone, I had to update this slide and these numbers and increase them from 12 to over 14,000 practices that are now recognized by NCQA PCMH. And I also had to update our provider number from 60 to over 82,000 clinicians that are currently participating in NCQA recognition. I think those numbers just speak for itself. Now, I will say there are other accrediting bodies like Joint Commission or URAC. There's also a number of local, state, and national PCMH recognition programs that exist. There's even some payer-specific PCMH programs I've seen and worked with. However, the NCQA program, I think, is the gold standard. It's what almost all EHR vendors recommend and work with. It truly is kind of the industry standard for patient-centered medical home, which is why I said in the beginning, if you're participating in one of those local, state, or even a payer PCMH, this webinar will most likely still be helpful to you because so many of their requirements probably align with NCQA because they probably modeled their program or their structure off of this as well. So how do you gain buy-in at your practice if you're new to PCMH? Or on the flip side, how do you sustain support if you're already recognized? I'm going to turn it over to Lexi, who is experienced in everyday practice operations. She's on site with our clients, boots on the ground, listening to their concerns daily to take us through how to elevate this conversation in your practices. So Lexi, it is all yours.
Okay, thank you, Lindsay. So I want to start by taking a look at two of the answers to the question, why PCMH? So first, as a practice, you can actually reduce fragmentation. And so that's going to improve quality. So the PCMH model emphasizes team-based care, communication, and coordination. And that's shown to lead to better care. So higher rates of fragmentation, they're also associated with higher costs, lower quality, and higher rates of preventable hospitalizations. Next, many payers acknowledge PCMH recognition as a hallmark of high quality care. So earning that NCQA PCMH recognition means you're providing patient-centered care that is associated with higher quality, better patient satisfaction, and a reduction in avoidable costly visits to the ED and hospital. So as a result, many payers actually provide incentives to NCQA recognized practices. These payers also offer benefits, and those can range from enhanced reimbursement to a preferred provider status, complimentary coaching and practice support. And we've also found that NCQA seal and your effort to improve quality can help you better negotiate with payers. The PCMH model is also associated with better staff satisfaction and patient experience. Another benefit to the PCMH model is that it's been showed to help better manage patients' chronic conditions, such as diabetes. So one study actually found that patients with diabetes had higher quality treatment than those not in an NCQA recognized PCMH. So as more emphasis is being placed on value-based care, many state and federal programs are embracing the patient-centered model of care. So MACRA actually rewards clinicians who earn NCQA patient-centered medical homes and patient-centered specialty practices recognition. So 29 public sector initiatives in 25 states actually require the use of the NCQA PCMH recognition as part of the medical home initiative. And states like Tennessee and New York are adopting PCMA recognition to help improve the overall quality of care in their states. We've also seen that research shows that NCQA PCMH recognition actually improves patient care and reduces costs. So there was one pilot program that showed a 9.3% reduction in emergency department utilization, and that resulted in approximately $5 million in savings per year. This study also showed a 10.3% reduction in ambulatory care sensitive inpatient admissions for patients that had 2 or more comorbidities. Another study found that PCMH recognition was associated with $265 lower average annual total for Medicare spending per beneficiary. There's also lower hospital spending and fewer emergency department visits. So PCMHs emphasize the use of health information technology and after-hours access, and that's going to help improve overall access to care when and where the patients need it. So there was a study that was found that PCMH practices rapidly increase office visits relative to non-patient-centered care clinics. So with 163 more office visits per 1,000 members each year. Another study found that PCMH patients had 77.5 more primary care visits on average and 17.3 fewer ambulatory care sensitive specialist visits. And that was for 1,000 patients per month. So this model can also help align your practice where healthcare is headed. So payers continue to move from that fee-for-service model towards rewarding integration and quality of care. So they're increasingly contracting with organizations that can show they have a strong infrastructure and quality improvement initiatives. And finally, the PCMH model, it's going to give you another avenue to market your practice. So the NCQA actually publishes a list of all recognized practices and clinicians in what it calls the recognition directory. So using the NCQA seal is going to allow you to market your accomplishment to patients and partners. So there are numerous clinician benefits that have been associated with this PCMH model. So first, the ability to earn higher reimbursement. So more than 100 payers nationwide offer either enhanced reimbursement for recognized clinicians or support for the practices that are recognized. Second, it can help clinicians succeed in MACRA. So the Centers for Medicare and Medicaid Services, or CMS, acknowledges both NCQA's PCMH and PCSP recognition programs as a way to receive that MACRA credit. So clinicians in an NCQA recognized program, they're automatically going to earn full credit in the MIPS improvement activities category. And as a result of that, they're likely to do well in other MIPS categories. The PCSP recognition program is the only specialty-focused evaluation program in the country that is actually recognized by CMS in MACRA. Clinicians can also earn what's called maintenance of certification credits. So several medical boards award clinicians in the NCQA recognized practices these MOC credits. So that's going to reduce the burden on your clinicians so they don't have to take on additional activities. This model is also going to allow clinicians to do what, let's be honest, they prefer to do, actually focus on their patient care. Another benefit that we've seen is reduced burnout. So the PCMH model is going to ensure that team members operate at their highest level of knowledge, skills, abilities, and license. So within those assigned roles and responsibilities. So the PCMH model, it's going to help streamline your processes and standardize procedures. So that's going to keep your practice's staff at the top of their knowledge, skills, and ability. And that has been shown to result in higher staff satisfaction. And finally, this model can also help improve your practice. So use of the NCQA PCMH recognition, it's going to let you perform gap analysis, and that's going to allow you to implement processes and procedures that are overall going to improve the care for your patients and make your practice more efficient. So in addition to all those clinician benefits that we just discussed, there are also several cost benefits. So studies have shown that within the PCMH model, there's actually a reduction in per capita expenditures that actually exceeds investment by commercial insurances and Medicaid. There's also going to be an opportunity for increased utilization of non-medical support services. And with this model, there's typically a decreased need to use specialists. And patient-centered care is proven to also decrease costs by eliminating those duplicative services. So this is typically achieved through better care coordination. And then finally, the PCMH model is going to encourage the prevention of expensive and oftentimes avoidable hospitalizations, emergency room visits, and complications. So practices that implement the PCMH model, they need to consider the business impact from investing in PCMH. And that will help you effectively plan for how the implementation of PCMH impacts your practice financially. So you have to ask yourself, what are the operational and financial considerations for becoming a PCMH recognized entity from the perspective of a primary care practice? So NCQA actually engaged Milliman, which is the world's largest provider of actuarial services, to help answer this question. So ultimately, when a practice evaluates whether to seek this NCQA recognition, leadership must determine whether the revenue potential outweighs the investment costs for PCMH. But revenue shouldn't be your only consideration. There are lots of other motivations for PCMA recognition, so such as the need for investment in quality improvement. It can help with creating or streamlining processes or procedures, and that's going to help reduce that staff burnout and create standardization within a system. And also, if you're operating in a competitive landscape, quality markers can help provide that competitive advantage. So if your practice is already participating in CMS's CPC Plus program, then lucky for you, you've probably already done most of the groundwork for PCMH. So practices are actually eligible for transfer credit, and that's as long as you've completed at least 2 quarterly CPC Plus reports or if you previously completed Classic CPC. So only 7 of those 40 core criteria are actually required to review. There are also 44 elective credits, and those can be eligible for automatic credit or attestation. So if you're currently participating in CPC Plus, you're almost done with the PCMH transformation. PCMH does overlap with many value-based requirements with state medical home programs, primary care first, other incentive programs such as MIPS, and other APMs.
All right. Well, great. Thank you, Lexi. I think that's important. I just think a lot of practices who are considering PCMH recognition aren't sure how to relay the value to upper management, or they're often tasked with the burden. Prove to me why this would benefit the practice and its patients. And even practices who already have recognition and we're phasing into this annual reporting, we're finding that having to provide evidence and pay a fee on an annual basis instead of 3 years, more clinicians and management are asking why they're doing this and is it worth it. So we wanted to provide you with the tools to elevate that conversation. So now on to the recognition structure, just as a high-level overview of eligibility and the process. In very broad terms, NCQA has broken down the recognition process into 3 parts: commit, transform, and succeed. During that commit phase, you're really gaining that physician, staff, and patient buy-in using those strategies we talked about previously. This is the time when the practice learns the NCQA PCMH concepts and begins to apply them in your practice. Then you go to transform. That's when you're actually participating in these activities and you actually begin to collect evidence to support those activities. And then lastly, succeed. And this is where you earn your recognition and then you partake in annual reporting each year to maintain it. So again, that's really the entire process from a high-level overview. So if you're asking yourself, this all sounds great, but where do I even begin, Lindsay? Well, the first place I would start is with eligibility. You need to know if you're eligible. So clinicians who are eligible are those that hold a current unrestricted license as an MD, a DO, an advanced practice nurse, or a PA. Only clinicians who can really be selected by a patient or a family as a personal clinician are eligible to be listed. And an eligible practice actually consists of 1 or more clinicians who practice together and provide primary patient care at a single geographic location. And practicing together means that all the clinicians in a practice follow those same procedures and protocols, and they have access to shared medical records for all patients that are treated at a practice site. These also need to be outpatient primary care practices, and a practice in NCQA's eyes, again, is a clinician or clinicians practicing together at a single geographic location. To kind of get specific here, this includes some nurse-led practices in certain states. It doesn't include any urgent care clinics or like clinics that are open on a seasonal basis. Now it's important to understand, and it's why I underlined it on the last slide, that recognition is achieved at the geographic site level. 1 recognition per address. For the MDs, DOs, PAs, and advanced practice RNs who are listed on the application, since all the clinicians at a site have to apply together. So clinicians should be listed at each site where they routinely see a panel of their patients, and any non-primary care clinicians should not be included. So what that means is that at least 75% of each clinician's patient should come for their first contact. They should be able to select them as their personal PCP, and they're the ones providing that continuous, comprehensive primary care services. Now there is multi-site eligibility, so for those of you who just had a mini heart attack when I said recognitions by site and 1 recognition per address, this is available, but you just have to be able to answer yes to all 3 of the following questions. So can you use 1 agreement, meaning you're 1 entity? Do all practice sites applying for recognition share and use in the same way? PM, EHR, et cetera, so if you're all on NextGen. And then 3, do all practice sites applying for recognition operate under at least some of the same policies and procedures? So each site isn't acting completely independent. You guys have some overarching policies and procedures in place that everyone is following. If you can answer yes to all of these, you're eligible for that multi-site recognition, which means you can share credit across sites. So you would have basically one primary practice that submits all the evidence, and then that would be shared by the rest. There are some criteria that are what's called site-specific, so every practice site would attest to that, but overall this makes the process much easier for those of you who are part of large multi-site practices. Now, taking a bit deeper than just commit, transform, and succeed, I wanted to hand it back over to Lexi just to quickly look at what changes were made to the PCMH program and compare it from that 2014 model to the new 2017 model. So Lexi, it's all yours.
Thank you, Lindsay. So like Lindsay just said, we're going to go over some of the goals of this new structure. So first, this new structure, it's going to emphasize that comprehensive integrated care. It's also going to allow for flexibility, so with multiple evidence types. It's going to support continuous practice transformation. And finally, it's going to provide focus and flexibility for your practice. So the current program is NCQA PCMH 2017. So that 2014 program ended on October 1st, 2017. So this redesigned program, that's going to include ongoing sustained recognition status, and that's accomplished with annual reporting. So it's going to be in place of the 3-year recognition cycle. So NCQA based this redesign on feedback from practices, policymakers, payers, and other stakeholders. They also considered the changing payment climate when it came to the new standards. Also, recent changes in federal law, MACRA, changed payments to reward value-based care. The redesigned processes are going to aim to align reporting requirements with MACRA changes, and so that's hopefully going to eliminate some duplication of work. This new program is also going to improve focus and flexibility while reducing the total criteria. So that criteria is going to go from 100 to 100 from 167 factors from 2014. Also, the new core and elective approach is going to allow practices to tailor the program to your specific population. So in my opinion, this program is going to be a lot more manageable. It's going to reduce paperwork, increase that NCQA interaction, while still continuing to concentrate on performance and quality improvement. So why are they making this change? So some of the common reasons were previously there was too much documentation. Practices also wanted more interaction with NCQA. The previous program was just too challenging for smaller practices. There's a call for less emphasis on the process and more emphasis on the performance. And practices should be demonstrating ongoing improvement as part of this program. So you can see here kind of an evolution of those PCMH standards. So that 2011 version of this program is pretty basic. So it did emphasize the idea of relationships with expectations of specialists, and it really underscored the importance of system cost savings. Then we see in 2014, they raised the bar a little bit. Behavioral health was further incorporated into the system. We also saw more of an emphasis on team-based care. And then in 2017, we saw the addition of the annual reporting requirements. We also saw a shift from focusing on structure to focusing on outcomes. So going forward, what can we expect? So this program is going to continue to evolve by adding and retiring any relevant criteria. We're also will see the annual reporting requirements are going to continue to be updated, and there's going to be more of an alignment with new programs and initiatives going forward. So you can see by this graphic, the PCMH model is constantly evolving and improving. So I'm going to send it back to Lindsay, and she's going to go over the standards and the scoring.
Perfect. Thank you, Lexi. So let's go ahead and dive into the new scoring structure and look at the standards. And I keep saying new. I mean, I guess 2017 now. October 2017 seems kind of far away at this point, but you never know. Some people may not be familiar with the new program if you're new, or you could still be on one of the 2014 models. So I will try and stop saying the word new for you all. But once you determine if you're eligible to become a PCMH, the next step is really understanding how recognition works and what your practice needs to do to meet the requirements. So let's look at the structure of the program. So today's program has evolved to feature a set of 6 concepts. These concepts make up the medical home, and they are really the overarching themes of PCMH. To earn recognition, your practice has to complete criteria in each concept area. So next is competencies. Competencies, they're really not that important if I'm being honest. It's just a way to categorize the criteria. They don't offer credit, they don't have any requirements. It's just a way to think about or group the criteria within a concept. Next is the criteria. These are the specific activities in which a practice engages in to demonstrate that it meets the recognition requirements. So these are the individual tasks or things you do to actually make you a PCMH and to actually transform your practice. Within the criteria are components, which are the individual parts of the criteria where evidence is attached. So important here, credit is assigned at the criteria level. That's probably the most important thing. Evidence to support that criteria or those activities is attached to the component. This took me a while to conceptualize and really get a grasp on how this works. It wasn't until I really dove into the standards and guidelines myself that I understood how this structure actually functions. So if you are confused, 1, don't worry, I'll explain it again. And 2, I am positive you are not alone on this call. As we talk through this, I think it'll make more sense. So the 6 concepts or overarching themes of PCMH are fairly straightforward. I actually selected this graphic on purpose with the different shape sizes just to basically show you which ones have the most amount of core criteria found in them. So you have team-based care and practice organization. This one focuses on things like practice leadership, care team responsibilities, and then the orientation of your patients and their families to what a PCMH is. As you can see, this is a smaller square, which means it doesn't have a lot of criteria, core criteria compared to the other standards. Next, kind of on the flip side here, is knowing and managing your patients. This deals with data collection, medication reconciliation, evidence-based clinical decision support, and connection with community resources. Obviously, a broad range of topics here. And you can see this is the largest standard with the most core criteria required by practices. Then we have patient-centered access and continuity, which includes criteria that's focused on access to the practice and clinical advice, care continuity, and of course, empanelment of your patients. We have care management and support, so that's identifying patients for care management, risk stratification, person-centered care plan development, things like that. Then we have care coordination and care transitions. That's really the management of lab and imaging results, tracking and managing patient referrals, and any care transitions. And then lastly, we have performance measurement and quality improvement. Another bigger one that focuses on collecting and analyzing performance data, setting practice goals, improving practice performance, and sharing practice performance data. So think of your ECQMs, your quality measures, things like that. So you'll see for every criteria a breakdown like the one above. So you have your concept, which uses a 2-letter abbreviation when identifying it, so TC for team-based care. Then the competency, which again, it's just that criteria subgroup, really not super important. And then the actual criteria, which states the PCMH requirements. It's always shown as a 2-letter abbreviation with a number after it, so TC01. And then you see you have evidence. Under the evidence, there are 2 components. This is where you attach that evidence to get credit for the criteria. So it can sound confusing when you're trying to talk it out, but I think this visual helps break it down and make it more meaningful to see how the structure actually works. So to receive recognition, practices have to complete all 40 core criteria and then earn 25 elective credits. Elective criteria are basically a mix of 1 to 2 credits, and you have to report on 5 out of the 6 concepts. And you can see on this image on the right, it's showing how many credits are available under each concept and competency. So you have 40 core criteria, and then you have 60 elective criteria that are available to you, and you just have to get 25 credits. So here's another graphic to better understand how the elective scoring works, and also one that shows you the breakdown of core criteria within each standard. This is going to show you exactly why I made the block different sizes on the previous slide. You can see knowing and managing your patients, or KM, and quality improvement, or QI, clearly have the most required core criteria compared to team-based care, TC, or care management, CM. Now, you may be wondering, okay, great, how do we meet this criteria, or how does NCQA know we met it? And that's where evidence comes into play. Practices must submit evidence demonstrating performance against specific criteria. They're encouraged to implement documented process-based evidence early, at least 3 months prior, and generally any reported data should be no more than 12 months old. So think of an audit. Whenever you're audited, you have to back up and prove you're doing something. This is the same concept. You need to prove you're actually meeting the criteria you selected by submitting evidence. And there are 2 types of evidence. One is a documented process, and the second is the evidence of implementation. So documented process is exactly what it sounds like. It's those written statements describing the practices, policies, and procedures. So you have protocols, you practice guidelines, other things that maybe you weren't thinking of, referral forms, flow sheets, checklists, etc. Those are all documented processes that your practice uses on a daily basis. Now, evidence of implementation, this is kind of broad. It's just a means of demonstrating systematic uptake. This could be anything from reports to practice materials like pamphlets, screenshots, website links, patient records, patient examples, surveys that you send out to patients, anything you enter into PASS, transfer credit you'd receive, etc. This really is the catch-all for anything that's not a documented process. Let me put it that way. So you can submit this evidence either online through the NCQA PCMH portal, which is called QPAS, or through what is called a virtual review, which is basically just like a Skype call with an NCQA evaluator. Now with QPAS, you're uploading things like policies and procedures, practice pamphlets, or a link to your website. These are things the evaluator can review on their own time. They don't need an explanation with it. This type of evidence can also be uploaded once and then linked to other criteria. So for example, you have something on your website that actually meets 2 criteria. You would upload the link once and link both criteria to it. It is extremely important to note you should never upload anything with PHI on it into QPAS. If you do decide to upload screenshots from your EHR to meet criteria, you would need to insert like a filled-in text box over the PHI in Word and then take a new screenshot of it covered. And that brings us to our second type of evidence, which is new and has received a ton of positive feedback, and that's a virtual review. So practice has 3 virtual reviews during transformation, and during this call, you're basically screen sharing with the NCQA evaluator on the call with them. So here, you don't have to hide any PHI. This is why EHR demos to meet certain criteria are encouraged versus a screenshot and removing PHI. You can also show reports and various patient examples during this time. So this new type of evidence can be a bit intimidating for the first time practices, but it really is to your benefit. This is also where I get the most amount of questions. So I covered virtual reviews in detail next, kind of with best practices and tips and tricks from multiple NCQA evaluators that I sat down with. So one last shot at trying to get you guys to thoroughly understand and walk away from this webinar understanding the concepts and structure of these criteria and concepts. So if we really put it all together, we have the concept, that overarching theme, the competency is just that bucket to group criteria in, and then the criteria with the actionable items. Evidence is what we actually submit to support that we're meeting that criteria. You have the 2 listed, and then you see this other area called guidance from NCQA. Guidance includes things like information on the intent of the criteria, your expectations, how it relates to other criteria, and certain aspects of the evaluation process. This is extremely helpful. Never overlook the guidance. But that's it. That's how you determine what's required of your practice to become a PCMH. It is the transformation of your practice to meet those requirements and provide that evidence. That's going to earn you recognition. So if we look at the actual process of gaining recognition, again, like I said, once you've met the core and elective criteria, what's left for us to look at is basically kind of that review process of looking at the virtual check-ins. We know the recognition basics of the readiness assessment and are you eligible. I think asking the question here of are you eligible, it's deeper than that. It's looking to make sure that you have practice leadership in place, a certified EHR, that you are already submitting CQMs, that your practice is already knowledgeable on the concepts and has already begun transformation into a PCMH. After that, you then enroll in QPAS, and by doing that, you would input information about your site and your clinicians, and once you sign the agreement and pay that fee, your 12-month transformation period officially begins. That's why I say you should really have already reviewed the requirements for PCMH and started making changes and getting things in place for at least the core criteria before you're officially starting in NCQA's eyes. Again, meeting with the NCQA rep, providing evidence during your 3 virtual check-ins, recognition, and then annual reporting. So here's where we are with this review process with the 3 virtual check-ins. During these, you really want to predetermine the criteria you're going to address and focus on documented processes first. Then identify your criteria for your 25 elective credits. Provide documents for off-site review, so policies, procedures, protocols, all of that before a virtual review. Then when you provide evidence during a virtual review, make sure you communicate with the evaluator. You can substitute evidence if they don't think something's sufficient, demo your system, and provide them reports. The great thing about these is that these virtual reviews are going to give you immediate and personalized feedback on what's going well and what you need to improve. So I understand it's intimidating or overwhelming, but it's actually so much easier and better for you to develop a relationship and get immediate feedback and get a better idea of what your evaluator is looking for. So what are some check-in tips and tricks? I have a feeling this will be a lot of people's favorite slide in the presentation. But first off, here are some things to keep in mind. These virtual reviews are limited to 2 hours. That's it. They do not go over. Second, you need to know you have a maximum and a minimum number of components you can check in or go over at each check-in. You actually mark these items in QPAS to go over them in their virtual review before you meet with them. So both of you know exactly what you're going to be presenting during that virtual review. My advice, try and complete everything in 2 reviews so you have an extra just in case you have any straggler criteria. Otherwise, you're actually going to have to purchase a 4th one. Due to the time and component restrictions, this is why we say upload all your documented processes beforehand. Also, transfer credit that you can achieve by your EHR vendor, which is the case with NextGen, which we'll look at towards the end here. This doesn't count towards your total component, so your min or your max. So those are freebies. This means you can mark those as done and then not include them in your total. Also, any shared credit, if you're multi-site eligible, will be reviewed at one practice and then marked met for the rest. So again, that's how you can kind of get away here with focusing on 2 reviews. The first one, really looking at the core criteria. You know you have to get these done. So make sure you look at those for the first review. Secondly, make sure you run any reports you plan on showing before the call. You don't want to waste precious minutes watching your EHR load a long report when those minutes are ticking away on your 2-hour time limit. Make sure if you're doing a demo, you have an actual patient example already pulled up, or if a screening tool is being used to meet criteria, that already needs to be filled out. Other kind of general tips and tricks include having the right staff available. Make sure you have all the necessary people in the room. Your nurses, someone from the front office, someone from billing, someone from IT if the internet goes down, your clinician if you need them, and also your CCE or your consultant who's helping you. Along those same lines, make sure you check your Skype setup and your mic connection before the call. If you're having technical issues, the clock doesn't stop. So make sure you have everything ready, your systems, your reports ready 15 minutes prior to check-in. And keep your descriptions and your explanations to the NCQ evaluator concise and to the point. You can always revisit topics, but let them ask you the questions. Keep things short, keep on topic. Again, these are all about preparation and organization to use your time wisely. You can get a lot done in 2 hours if you're prepared. So after the check-ins, you can log into QPath and you're going to see your evaluator either marked criteria as met or not met. After all 3 check-ins, you need to have all the core and 25 elective credits completed. If you don't, there is an additional virtual review available for purchase. And if the process isn't completed within 12 months, you can purchase additional time. So all that's great. You have to upload evidence or show it in a virtual review, but we, again, wanted this presentation to be meaningful to help you understand what NCQA is actually looking for. So I did pull 1 to 2 criteria from each standard just to briefly show you some examples of evidence. Just due to time, I might only do 1 of these from each slide, but again, we'll be sending this out afterwards. So first is just team-based care and practice organization. So if we're looking at TCO2, this says define practice organizational structure and staff responsibilities or skills. So you can actually just provide an org chart to meet this criteria and upload it to QPath. Done. However, lesson 1 with meeting criteria, read the description and take it literally. It says structure and role and responsibility. That means if you uploaded an org chart that didn't list their responsibilities under their title, it would not meet both parts. So look at the example image on the top. This has both. You could submit an org chart that just has the role and name that shows the structure, and then submit job descriptions for each role if you already have those. And that's lesson number 2. Evidence is flexible. NCQA encourages practices to do what works best for you and to think outside of the box to meet criteria. There really is no one-size-fits-all when it comes to evidence. It's really not the point. It should be unique to what fits your practice. So moving on to knowing and managing your patients, this section will likely rely heavily on your EHR. So if we look at KMO 3, this is conducts depression screening using a standardized tool. You can see I included screenshots from NextGen of the PHQ2 and PHQ9. Also note this example of this template, it's filled out. That's key for any screening tool you show. It needs to be filled out. You can't submit a blank template for a screening or a survey. This also may be a good one that you'd want to show during a virtual review as a demo. Another good lesson here is always pay attention to the components needed for each criteria. A lot of times you'll need a report and evidence of implementation, or evidence of implementation and a documented process, which means you have to submit both of those things before the criteria can be marked as met. KMO 9 here, just what I wanted to point out. You're assessing the diversity of your population. One thing here, you might be wondering, wait a minute, how do they know to show race, ethnicity, and a vulnerable population and language? All of those required parts were most likely explained in the guidance under that criteria. So that's why I always say don't skip over it, or you're most likely going to leave out a key piece of information that NCQA needs. Patient-centered access and continuity. Again, if we look at that top screenshot, you can see survey results and answers to meet this criteria. Another kind of lesson learned here, with surveys, you can't ask yes or no questions. These questions need to be actionable. So what that means, and again, I'm just making one off the top of my head now, you can't ask, would opening another location for our practice better serve you? You would need to ask, would opening a better location in this zip code better serve you? And if not, what zip code do you live in? You're getting data that you can take action on as a practice. Care management and support, CMO 5, just giving patients access to their care plan. Again, don't overthink it. It really is as simple as it sounds. And then CMO 3, identifying patients at high risk using risk stratification. This is just a screen grab of NextGen showing NextGen analytics at work here. One thing I will point out here is that you could run into, if you meet CMO 3, you get automatic credit for CMO 1. That does happen, so you want to pay attention. And like I said, there are just some ways that you can kind of kill two birds with one stone. Care coordination, just great examples here of how there's no one-size-fits-all and evidence is flexible. You could submit this Excel spreadsheet that is gathering information on consultants and specialists, but you could also come into Physician Compare website and take a screenshot on the specialist that you refer out to. There's so many different ways that you can meet criteria. NCQA is not prescriptive at all. With CC01, one thing I did want to point out, this is one that requires a documented process, but also evidence of implementation. So you can see the level of detail this practice went to. Want to call out there's an effective date and an issue date. Again, needs to be in place for at least 3 months before you are able to submit it for credit. And then you could also have a screenshot from your EHR show that in the demo as well. One thing I will say, if you're worried about documented processes, let's say you have processes that your practices use, but maybe they just aren't documented. There are a whole lot of examples out there. In fact, MGMA actually has a whole book of policies that you could purchase to review and tailor to your practice. One thing I will say, NCQA hates templates. So definitely not suggesting that you go online and try and copy your policies and procedures. Do whatever works best for your practice. They really do accept anything that's prescriptive and works in your practice setting. And then lastly is performance management and quality improvement. What I'm trying to get across here is this is stuff you guys are probably all doing based on your other value-based care programs you're participating in. And just screenshots of your HQM and doing a demo of your HQM can meet a ton of these as well. But again, meeting this criteria, it's not about reinventing the wheel. It's about making your practice more patient-centered. So if you're already doing all of these things, that's great. That's a huge bonus. So kind of our key takeaways and themes, just from a CCE's perspective, from working with clients and from working with NCQA hand in hand. First is one that we talked about. Evidence can be flexible. We saw this with the different things that you can submit. 2, many criteria require multiple types of evidence. That documented process plus evidence implementation is going to be very common. Screening tools and templates have to be completed. They can't be submitted blank. And then 2 that I will call out that we didn't focus on yet that are extremely important. The first is that criteria focuses on the entire patient population. So a lot of times we tend to collect data or focus on a subset of patients unintentionally. For example, with team-based care measures, where we put information on a medical home pamphlet. So one of the measures is basically orient your patients to what a patient-centered medical home is. If we handed out a pamphlet to new patients, that wouldn't meet that criteria because you're only focusing on a subset of patients, new patients. In the same instance, if we put that on our website, if we have a large population of patients who don't have access to the internet, we're only focusing on a subsection of the population. So it takes some kind of out-of-the-box thinking to apply criteria that focuses on the entire patient population. And then kind of on the flip side of that, if the criteria includes the verbiage vulnerable population, that has to be focused on. You have to pick a population that is considered vulnerable. So certain ethnicities or Hispanic, single moms, homeless, veterans, all of these are vulnerable populations, but you couldn't compare things like literacy rates in girls versus boys. One of those is not a vulnerable population. It wouldn't work. So those are 2 major themes that we see popping up, especially in virtual reviews of the NCQA evaluator digging deeper and asking questions, and those being an information gap for practices. The last thing too is in care management, a lot of times we have patients numbered as patient 1, and we don't actually know who patient 1 is. So if the NCQA evaluator asks to look at patient 1 in care management's chart, you need to know who they actually are. Again, just kind of lessons learned here that I was pulling off the top of my head to give you all as kind of best tips to succeed. So I know we are essentially out of time here. We were just going to get into annual reporting. Not too much to go through here. Really, we were just looking at quickly the annual reporting process. There's a few different ways you can get there, and basically it depends on what PCMH level you are. These are pretty straightforward, and we'll send out and keep in the slides. Basically, if you're PCMH 2011 or level 1 and 2 for 2014, you have what's called an accelerated renewal, where you'll have some attestation components and some review components. And then PCMH 2014 Level 3 just goes directly to annual reporting. You can pass go and collect your $200. What it is that you have to complete your annual reporting 30 days before your anniversary date, which is when you would have set to expire. You have to attest that you're continuing with these activities and then provide evidence for some activities. So this kind of breaks it down really, really easily. Attest to previous performance, confirm any practice changes or clinician changes, provide very limited evidence, and then pay an annual fee. A lot of practices were saying they were nervous. They felt like they were underwater, that this was moving from 3 years to 1 year, and that was not the intent by NCQA at all. And I think at these reporting requirements, on the left-hand side, you can see there's almost one under each of the 6 concepts, and it's the things that you guys are probably doing on a daily basis. So again, not too difficult. We'll be sending out a copy of the slide deck, and we'll also be including the 2020 annual reporting requirements. That's one thing I wanted to point out, is that right now we're looking at the 2019 annual reporting requirements. If your annual reporting date, which is 30 days prior to your expiration date, is in 2019, you follow 2019. If it's in 2020, you have to follow the 2020 requirements. And those are released every year, 6 months prior. So every July, those updated annual reporting requirements are released. So just kind of top annual reporting pitfalls. I won't go through all of these. The main one I really wanted to focus on is overthinking. It really isn't as difficult as people are making it seem. They're building it up in their mind, so don't think. Lastly, again, there is a chance of an audit. With NCQA now, it happens after annual reporting, and if you're selected for an audit, you just have to demonstrate the core PCMH criteria. So our last section was just how we can help, basically going over what NextGen can offer you. So what we're looking at, NextGen is a pre-validated EHR vendor, meaning that if you're using NextGen EHR, you actually already are earning 31 transfer credits, or you've already met 31 criteria, already adding to your score. And they actually have practice support approval for 21 of those. NextGen Office has 6 core met, and then I believe it is 16 practice support. So you can see the breakdown on here. If you are using NextGen, this is huge. This really breaks down how you would report and how you'd handle those virtual reviews, because you've met so many already. There's things on the success community like this matrix capabilities. This is really helpful. It's showing you what you get transfer credit for, and if there's a report available for it. So that's extremely helpful and downloadable. Where you would access this is actually on that PCMH and PCSP resources page in the success community. You also have access to white papers that actually take you through workflows on how to show that you're meeting a certain criteria, which is great to have on hand for a virtual review. And then they also actually offer a reporting suite. So if you're worried about this, it covers all of those criteria you see on the right-hand side. These are actually used to be crystal reports, and now they're SSRS reports. You would just reach out to your NextGen account rep, or if you are going through a reseller, at Tenem specifically, we can obviously help with installation and technical aspects. We have had a client recently do this, and they were able to give us some feedback that they recently purchased the PCMH report package, and they highly recommend them. They have 10 sites right now that are currently PCMH recognized, and they've made the process a lot easier for them. And they've actually found other uses for these reports besides just PCMH. And lastly, how we can help. That's me, your PCMH CCE. If you need help with transformation or with annual reporting, what a certified content expert is. I went through in-person training. I also took an exam. Basically, it's an expert to facilitate practice transformation. Really, it can do whatever your practice needs in regards to PCMH, help you prepare for virtual check-ins, help you get a timeline, help identify what criteria you need to focus on and when, and then help you with annual reporting as well. So I know the last slides were a bit rushed through. Again, nothing crazy different here. compared to last time we did a similar presentation. We are going to send the slide decks out, and we are going to send the 2020 annual reporting requirements out for practices who do need to do that. If you're uncertain where your practice stands, please let us help. If you have next steps or you're interested in anything that ITENIV does, or specifically PCMH support, you can visit our website. Please sign up for our webinars and continue to do our blog. We also have our fixed price macro packages that has kind of been expanded recently to going beyond MIPS, but also PCMH and CPT Plus and things like that. And then of course we have our 3-day fixed price on-site consultations. So if you need help with that gap analysis, we can do that on the EHR side, the PM side, and even technology. So we have made it to questions. So Chelsea, I will let you take over from here. If you guys have any very specific questions on certain criteria, I don't have the standard and guidelines up in front of me because you guys are seeing my screen right now. So I would have to get back to you on that, but I will do my best to answer anything I can.
Hey, thanks, Lindsay. Okay, so it looks like we only have one question so far, and it's not super questiony. So if you have questions, ask them, and we'll hang around and answer all of them as they come. So somebody wanted to say some of the PCMH reports are not very clear to the surveyors.
Okay, thank you for letting us know that. So they do actually, what the PCMH reports come with is a report guide and spec sheet. So it shows you how the report captures certain workflows. So I have heard that a lot of times you'll have to take the surveyors through that specific workflow so they can see the functionality of what the report is pulling, and then they get a much better idea with that. So with that reporting suite comes that guide and that spec sheet that you should be able to actually share with the surveyor as well. And they can work.
Great, thank you, Lindsay. Next question, can you go over how we remove the patient information from the screenshots again?
Sure. So there's a bunch of different ways you can do this. Basically, whatever screenshotting tool you're using, I would take that. You can either copy and paste it into Paint and actually select the PHI and then delete it, and then take a screenshot of it. You can also take that screenshot. I've copied and pasted it into Word and inserted a text box over it and filled the text box in with like black, and then taken a screenshot over that image as well. The idea here is obviously hiding or deleting the PHI and then retaking the screenshot. You don't want to save it as a PDF or just save the Word document with the text box over it, because if someone opens it, you can remove the text box, you can move it around or delete it. So taking that second screenshot is my best practice recommendation. And on that same note, I definitely would recommend, that's just a large admin burden, and that's largely why the virtual reviews came into play. People were sick of having to take screenshots of their EHR system and constantly black out PHI. So I would definitely encourage you to use the virtual reviews for any kind of EHR demos or patient examples.
Great, thanks, Lindsay. And as somebody who works a lot in Adobe and whatnot, I do want to add, saving it as a PDF won't work, but if you were to do one of those examples, like Lindsay said, in Paint, you could save it as an image with the blacked out image or the blacked out shape over it, and that also does save over the PHI, so you could go that route as well. Well, it looks like that's all the questions we have. Sorry that we went over a few minutes, everyone. Thanks for sticking with us. If you have any further questions, you see Lindsay's and Lexi's information up on the screen. Feel free to reach out to them. Otherwise, you can always reply back to the email that I'll send within the next week with the slides and the recording. Any way that you can get a hold of us, we're happy to help. So just let us know, and thank you so much, and have a great week.
Great. Thank you, everyone.